Introduction. A patient who is having difficulty breathing requires immediate care. Respiratory distress can quickly progress to respiratory failure, respiratory arrest, and cardiac arrest. Pathophysiologic mechanisms contributing to respiratory emergencies. Respiratory emergencies arise due to problems with ventilation, diffusion, gas exchange, or perfusion. Problems with these processes may have many different sources. Inadequate ventilation. Problems with ventilation occur in the presence of conditions that affect the body's ability to move air in and out of the lungs. Conditions that can lead to impaired ventilation include airway obstruction, neuromuscular conditions, central nervous system conditions, chronic lung disease, and trauma. Inadequate diffusion and perfusion. When diffusion is impaired, the exchange of oxygen and carbon dioxide between the alveoli and the pulmonary capillaries is affected. Respiratory distress represents the earliest stage on the continuum. A patient in respiratory distress is using compensatory mechanisms to maintain adequate oxygenation and ventilation. The patient's work of breathing is increased, but physiologically, oxygenation and ventilation are adequate to meet metabolic demands. However, if the patient's respiratory distress is not relieved, these compensatory mechanisms will soon become inadequate, at which point the patient may develop respiratory failure. Signs and symptoms of respiratory distress may include dyspnea, use of accessory muscles to assist in breathing, evidenced by supraclavicular, suprasternal, intercostal, or substernal retractions, diaphoresis, irritability, restlessness or anxiety, changes in level of consciousness, cyanosis, decreased, absent, or abnormal breath sounds, for example, wheezes, crackles, rhonchi, speech dyspnea, changes in breathing rate or depth, tachycardia or bradycardia, decreasing O2 saturation levels, and end-tidal carbon dioxide levels that are initially low, less than 35 mmHg, but with increasing distress move into the normal range, 35 to 45 mmHg, and then become elevated, greater than 45 mmHg. Respiratory failure occurs when the respiratory system can no longer meet metabolic demands. Respiratory failure usually represents a progression from respiratory distress, but patients may also initially present in respiratory failure. Respiratory failure must be addressed quickly to prevent respiratory arrest. Signs of respiratory failure could include changes in the level of consciousness, cyanosis, O2 saturation values less than 90%, end-tidal CO2 values greater than 50 mmHg, tachycardia, and a decreased or irregular respiratory rate. Respiratory arrest is complete cessation of the breathing effort. The body can tolerate respiratory arrest for only a very short time before the heart stops functioning as well, leading to cardiac arrest. Patient assessment. Data gathered during the rapid, primary, and secondary assessments can help you to determine where the patient is on the continuum of respiratory compromise and may offer clues as to the underlying cause. Signs of respiratory compromise that you may observe during the rapid assessment include retractions and the use of accessory muscles to breathe, tripod positioning, an inability to speak in complete sentences, or at all, pale, ashen, or cyanotic skin, diaphoresis, and restlessness, agitation, or an altered level of consciousness. Conduct a primary assessment following the ABCDE approach and provide initial interventions as needed. Ensure a patent airway, assist with ventilation as necessary, which is initially provided using a bagged valve mask resuscitator. Establish pulse oximetry, and provide the minimal level of supplemental oxygen needed to maintain an oxygen saturation of 94% to 99%. Establish capnography and adjust ventilations as needed to maintain carbon dioxide levels in physiologic range between 35 and 45 mmHg or monitored using end-tidal CO2 unless another target is clinically indicated, and establish vascular access. The secondary assessment will often help to further discern the underlying cause of the respiratory compromise and evaluate the severity of the patient's condition. For a patient with respiratory compromise, interventions depend on the underlying cause. Common interventions include supplemental oxygen, medications specific to the underlying cause, and assisted ventilation, non-invasive ventilation, or invasive ventilation. After any intervention, reassess the patient to determine response and adjust the treatment plan as necessary. Monitor the patient for signs of worsening respiratory function, such as increased work of breathing, an increase or decrease in respiratory rate, hypoxemia, or mental status changes. Use the pulse oximetry and capnography for continuous monitoring. If the patient in respiratory arrest is not breathing but has a pulse, ensure a patent airway and deliver one ventilation every 6 seconds. Provide ventilations by BVM initially. Provide mechanical ventilation as indicated. Provide high-flow supplemental oxygen, titrating to achieve and maintain an oxygen saturation of 94% to 99%. While supporting ventilation, consider and address potential underlying causes. Perform a primary assessment and provide emergent initial interventions if not already done. Continue to check breathing and pulse every 2 minutes. If the pulse becomes absent, begin CPR immediately. Position the patient as appropriate for their clinical condition and perform a secondary assessment as the patient's condition allows.